Welcome to AETCM, the emergency medicine channel. Today let us discuss about rheumatoid arthritis. When we discuss about rheumatoid arthritis, we should know the classification of arthritis. Basically, the joint problems are divided into arthralgias and arthritis. Arthritis means inflammation of joint. In that inflammation of joint, again you have monoarticular joint inflammation and polyarticular joint inflammation. In monoarticular, again acute problems are due to trauma, septic arthritis, gout, that is increased uric acid, pseudo gout, and rarely it can be rheumatoid arthritis. Chronic monoarthritis is osteoarthritis is common, mainly knee joint and ankle joint. TB can come as monoarticular involvement, spine involvement, hip involvement, all those things are classically in TB. Psoriatic arthritis, mainly finger joints and spine involvement can be there. RA can be rarely seen as a chronic monoarticular involvement. If you see polyarthritis, the most important deforming polyarthritis is rheumatoid arthritis. You can see the symmetrical polyarthritis, RA, osteoarthritis, psoriatic arthritis. Asymmetrical, again ankylosing spondylitis, psoriatic arthritis, osteoarthritis, IBD related arthritis, reactive arthritis. Migrating non-deforming arthritis, rheumatic fever. Non-migrating non-deforming arthritis, SLE and reactive arthritis. So you can see some of the arthritis here can be there in almost all types, like RA can be there in many types of presentation. Psoriatic arthritis can be in many types of presentation. Reactive arthritis can be there in many types of presentation. Osteoarthritis can be there in many types of presentation. So clinical features may be there, like some of the clinical features may share with other types of the arthritis also. Whatever it is, most of these arthritis are inflammatory joint disorders and some are induced by some antibodies. So that is very, very important. That means it is inflammatory immune mediated joint involvement. Now rheumatoid arthritis is an immune mediated disease. It's mainly seen in female patients. Around the age group is around 30 to 50. That's why when the patient is in a younger age group, if the patient come with symmetrical joint disorder, that is mostly rheumatic arthritis. If the patient is very young, like a child coming with migrating arthritis, it will be rheumatic fever induced arthritis. Whereas old age, after 50 years, mostly it is osteoarthritis. So the clinical features may be sometimes interlinked between different types of arthritis. Age is also interlinked between some arthritis. So it will be very difficult to identify what type of arthritis we are dealing with. So sometimes you have to take a detailed history, clinical examination, lab investigation. Putting all together only you can make a clinical diagnosis. 50% of the cases are associated with actually DR4, but in Indian population DR1 is more important than DR4. You can see the joint here. Joint is destructed by antibodies. When it is destructed, the bones, the tip of the bone can have a friction. There will be edema. There will be joint destruction. So many abnormalities can be there in the joint. So it's an inflammatory, immune-mediated inflammatory disease of the joint. But these joint disorders mainly affecting the smaller joints, not the larger joints. That is also very important. So here what you are seeing is an immune complex producing destruction in the articular sites. They produce chronic inflammation, persistent synovitis, proliferation of synovium into folds, and ultimately it will become thickened and hyperplastic. So that is a problem in rheumatoid arthritis. So slowly the bone surrounding the joint will be destructed. So macrophages, plasma cells and lymphocytes all will infiltrate to joint space, and initially they will produce edema, then it will produce inflammation, then it will produce bone destruction and osteopenia. So that is very important. So cartilage in between two bones will be destroyed. So the bones again they develop friction between two bones and destruction will increase. If you see the clinical feature of rheumatic rheumatoid arthritis, that is very, very classical. They all present with early morning stiffness. Most of these patients will have difficulty in bending or difficulty in moving the upper limb joints, mainly the finger joints. So early morning stiffness that may last for 45 minutes to 1 hour. Then arthritis will be there in 3 or more joints. That is very important, especially small joints of hand like proximal interphalangeal joint, metacarpophalangeal joints, wrist joints. All these small joints are involved in the hand joint. So wrist, metacarpophalangeal, proximal interphalangeal joints are the classical joint involvement in rheumatoid arthritis. Symmetrical arthritis is very, very important. You can see in psoriatic arthritis or ankylosing spondylitis, they are asymmetrical arthritis. Here what you are seeing is symmetrical. Both sides will be involved at the same time and the progression also will be same. The progression is in the both upper limbs, it will be same. Now rheumatoid nodules can be present in many patients. That will be extensor aspects of the hands, that is mainly seen on the hands, extensor aspects of hands. You can see some nodules, that is called as rheumatoid nodules. Some X-ray changes are classical for rheumatoid arthritis, that we'll see afterwards. Rheumatoid factor will be positive in many patients who is having rheumatoid arthritis, but remember that rheumatoid factor can be positive even in a normal person. So rheumatoid factor alone will not make any diagnosis of rheumatoid arthritis. The associated clinical findings are classical, like patient can have small joints of hand involved, symmetrical hand involvement. So all these things are very important, and with that, if the patient is having rheumatoid factor positive, then that is significant. Suppose the patient is having clinical findings of SLE and rheumatoid factor is positive, then it is something else. And if the patient is having psoriasis and arthritis, if rheumatoid factor is positive, that doesn't mean that patient is having rheumatoid arthritis. Rheumatoid factor is one of the tests or one of the criteria to make a diagnosis of rheumatoid arthritis. So there is a classification criteria and scoring is also given. If the score is more than 6, there is a definitive sign of rheumatoid arthritis. Now, if you see the arthritis, I already discussed that patient can have symmetrical joint involvement, mainly upper limb joint involvement, mainly small joints in the upper limbs are involved. Proximal interphalangeal joints are more involved than distal interphalangeal joints. Metacarpophalangeal joints are involved, wrist joints are involved, elbow joints are involved, and some of the lower limb joints also involved. But it is predominantly upper limb joint involvement, predominantly small joint involvement, predominantly proximal joints involvement. That is a classical. Most of these patients have chronic progressive arthritis. Some have palindromic presentation, that is short-lived arthritis. 1 or 2 days patient can have severe arthritis, completely disappears. Like previous slide we have seen, rarely patient can have mono-articular involvement, that may lead to asymmetrical joint involvement, but these type of presentations are rare. And one important thing is, again, rheumatoid arthritis is classified into, or inflammatory arthritis are classified into rheumatoid factor positive and rheumatoid factor negative. And if the rheumatoid factor positive, it is called as rheumatoid factor positive rheumatoid arthritis. If it is negative, rheumatoid factor negative RA. So these things we have to know, because some of the patients who is having typical presentation of rheumatoid arthritis, they may not have rheumatoid factor positive. That doesn't mean that patient is not having rheumatoid arthritis, they have rheumatoid arthritis. It is sometimes called as seropositive or seronegative rheumatoid arthritis. Spine involvement is not very common in rheumatoid arthritis, but rarely cervical spines are involved. Cervical spine subluxation can come, and some of the patient can come to emergency room with cervical spine subluxation. Other joint involvement: temporomandibular, acromioclavicular, sternoclavicular, cricothyroid joint involvement is also seen in rheumatoid arthritis. Hip and sacroiliac joint involvement is not very classical like ankylosing spondylitis. It is not at all seen. Now this picture shows the deformities are formed here. The upper limb deformities, you can see different types of deformities: Rheumatic deformity, bottom-ear deformity, Z deformity of the thumb. And the first picture shows the proximal interphalangeal joints are more involved, distal interphalangeal joints are not involved, and patient can have a symmetrical arthritis. That is also very important, symmetrical arthritis. Now there are different types of, since it's a deforming arthritis, after destruction the joint can be deformed. So there are different types of deformity: Swan-neck deformity, hyperextended PIP joints and flexed DIP joints. Bottom-ear deformity, so PIP is flexed and hyperextension of DIP joints. Ulnar deviation of the wrist and fingers. Z deformity of the thumb, and hammer toe deformity in the lower limbs. So these are the common deformities like Swan-neck, bottom-ear, ulnar deviation, Z deformity, and hammer toe. These are the commonly seen deformities in many types of arthritis, including rheumatoid arthritis. Now this is one classical finding seen in rheumatoid arthritis, that is rheumatoid nodules. So these are nodules seen in the extensor aspects of the upper limb. They are classically seen in the upper limb. So they can be in the arm or forearm. You can see the swellings like that. So they are called as rheumatoid nodules. Now 7 classical features of RA, you can remember it as RF rises. Rheumatoid factor positive, finger and hand joints are predominantly involved. That itself, proximal interphalangeal joints are classically involved. Rheumatoid nodules are seen in many patients. Involvement of 3 or more joints, stiffness of joints, especially in the early morning hours. Erosions of joints can be seen by osteopenia in the joint site by X-ray. Symmetrical joint involvement, that is classical presentation. Bilateral, symmetrical, progressive erosion of the joints are called as rheumatoid arthritis. Now we have already seen that rheumatoid factor is one of the serological tests for rheumatoid arthritis. So rheumatoid factor will be positive in 70% of the cases. It has got a prognostic value also. That means the high value will have a bad prognosis, low value will have a better prognosis. But remember, negative in 30% of the patients who is having early illness, and initially negative can repeat after 6 months to see whether the factor is again present or not. But nowadays we don't do repeat rheumatoid factor test. Just once it is diagnosed as RF positive or RF negative rheumatoid arthritis, and treat the patient accordingly. Another important test is anti-citrullinated cyclical peptide antibodies, ACCP ELISA. Its specificity is 90, sensitivity is 60%. So this can be done in almost all patients who is having rheumatoid arthritis. Many of them will have a positive ACCP, and it also gives a good prognostic value for rheumatoid arthritis. It is more specific than rheumatoid factor, because rheumatoid factor can be positive in so many conditions, including normal persons also it can be positive. But here ACCP is mostly present in rheumatoid arthritis, and rarely you can even see this ACCP before the onset of arthritis. That is also seen in some patients. So this is a very early marker of rheumatoid arthritis. So now next is extra articular involvement of RA. In that, if you see, almost all organs in our body is involved by rheumatoid arthritis. So we will not be going to all details of all these things. So we have to investigate for all these extra articular manifestation. In these few are very, very important. One is lungs. Many patients with rheumatoid arthritis can have lung fibrosis, interstitial lung disease. The problem with that is patient who is having methotrexate also can have lung fibrosis because of methotrexate. So during treatment we will have difficulty whether the lung fibrosis is due to rheumatoid arthritis or due to the methotrexate. So that difficulty can occur during the treatment of rheumatoid arthritis with methotrexate. Another important thing is many patients will have peripheral neuropathy, entrapment neuropathy, like that. Neuropathical complications are very common in rheumatoid arthritis. Another important problem is many patients can have pancytopenia, neutropenia, anemia, thrombocytopenia, like that. Hematological complications also seen in many patients. Other than that, eye involvement can be seen in some patients. Eye checkup is very, very important. One is rheumatoid arthritis can have eye findings. Another one is when we are treating the patient with hydroxychloroquine sulfate, we have to send this patient for periodic eye checkup for the risk factors of eye involvement in hydroxychloroquine sulfate tablet. Now, X-rays mainly pick up soft tissue swelling, periarticular osteopenia, bone erosions, articular cartilage erosions, joint space narrowing, like that. We get lot of findings from X-rays of patients who is having rheumatoid arthritis. Like in a patient who is having rheumatoid arthritis, if we take the X-ray early itself, we can see some changes in the joint spaces. But that doesn't help a physician to make a diagnosis of rheumatoid arthritis, because it's mainly the rheumatoid arthritis diagnosis is mainly a clinical diagnosis than the investigational part of the diagnosis. It's mainly a clinical diagnosis. So clinical symptoms are very, very important. X-ray and other investigation may only help the physician to make a proper diagnosis. Now, when we are treating rheumatoid arthritis, we should know that it's an inflammatory, immune-mediated joint destruction. If we don't act fast, the joint may be completely destroyed. Once it is destroyed, it will be very difficult to get back the function of the joint. So, initially, what we thought is start lower, small drugs in a lower dose and hike up the dose, add another drug, add one more drug, like that. It is a pyramid-like treatment, go up slowly. But nowadays, most of the physicians or most of the guidelines say that start with maximum dose and slowly come down. So they started using biological DMARDs, like that. Higher efficiency drugs are nowadays used for treatment. So first of all, when we are treating rheumatoid arthritis, we have to start the pain relief tablets. We routinely treat the patient with paracetamol 1 gram TID to pain relief, or diclofenac, or any other NSAIDs. So only problem with chronic NSAID use is they can have GI ulcers or other complication, hypertension, all these things due to these NSAIDs. So hypertension, renal disease, liver disease, all due to these NSAIDs. So we have to be very careful when we are treating the patients with chronic NSAID use. So paracetamol is a safe drug. 1 gram TID can be given in most of the patients. Other one is steroids. We can start steroids, either high dose 1 milligram per kg body weight steroid can be started instead of NSAIDs, so that the joint destruction, inflammation, all can come down. But we should remember that they have their own side effects. So steroids are mainly used. We use prednisolone 1 milligram per kg body weight. For example, a 70 kg male with rheumatoid arthritis, we start 60 to 70 milligram of steroid, then taper it down. So every week you can reduce 10 milligram, and ultimately it may end up in 7.5 milligram daily, then 7.5 milligram alternate days, and along with that we have to continue and DMARD, that we'll see afterwards. Then discontinue the steroid, because steroid has got a lot of side effects like diabetes, hypertension, osteoporosis. So many side effects are there. So steroids can be started as a bridge therapy between the acute symptom to onset of DMARD treatment. So disease modifying treatment, anti-rheumatoid drugs are mainly methotrexate. You can start 25 milligram of methotrexate weekly with folic acid, slowly taper down it to either every week you can reduce to 20 milligram, then 15 milligram, 10 milligram, 7.5 milligram is the least possible dose. So weekly once you can give methotrexate with folic acid. It's an anti-folate drug, so always give folic acid. If the patient develops neutropenia, we have to give folinic acid, that's a treatment of choice in methotrexate induced myelosuppression. Hydroxychloroquine is another drug. You can give 200 to 400 milligram. It can produce darkening of skin, and some eye checkup is required periodically to rule out the complications of hydroxychloroquine. Sulfasalazine is another drug that can be given as 500 milligram TID or 1 gram TID. Leflunomide can be started as 100 milligram per day, then 10 to 20 milligram per day can be continued. During the therapy with all these drugs, we have to check the liver function test, renal function test, blood counts, all these things, and HCQS, again eye checkup is very, very important to rule out retinal pigmentation. So this chart will help you to go according to severity, but whatever it is, we start NSAIDs, paracetamol, then steroids, then along with that we start DMARD in a higher dose and taper down. Some physicians start with lower dose and taper up, but ideal situation is start with higher dose and taper down. So instead of this method, we can go for a higher drug like biological DMARD. That also we'll see. Biological DMARD means they are biological agents, engineered drugs that targeted to specific inflammatory cells. They are not like steroids. Steroids act against general immunity, but they are acting against specific antibodies. These are the biological available: infliximab, etanercept, adalimumab, rituximab, anakinra, tocilizumab. See, these are the common drugs we use, but they can be used in different other conditions also, other than rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, Crohn's disease, ulcerative colitis. All these things also we can try all these drugs. So we are having so many drugs, anti-TNF antibodies like etanercept, infliximab, adalimumab. So many drugs are there. I am just telling one of its slides are given so many drugs. Infliximab is one important drug. It's a chimeric monoclonal antibody. It can be given as 3 milligram per kg body weight at first day, then second day, and 6 weeks, then 8 weeks thereafter. That is a dose of infliximab. Rituximab is another important drug that also we use in rheumatoid arthritis. It can be given as IV infusion, 1000 mg, that is 1 gram on day 1 and 15, combination with methotrexate. That means we have to continue methotrexate. They are normal DMARDs, and these biological drugs are highly efficient immunosuppressants, but they suppress only some part of the immunity. Like here it is anti-TNF antibodies. So they may not inhibit other parts of the immunity, but whereas steroids are giving a general reduction in the immunity. So patient can have severe immunodeficiency when we compare with these biologicals. Anti-interleukin-1 anakinra is another drug that is also used in rheumatoid arthritis, subcutaneous 100 milligram once daily. So that is a treatment for severe rheumatoid arthritis that can be started early in rheumatoid arthritis. Anti-interleukin-6 receptor monoclonal antibody, that is tocilizumab. So that is also can be given in patients who is having rheumatoid arthritis if they are not responding to routine treatment and routine DMARDs or routine biological DMARDs. Initial dose is 4 milligram per kg IV every 4th hourly, may be increased to 8 milligram per kg based on clinical response. So these are the commonly used drugs. Other drugs like abatacept, it's a disease modifying T cell co-stimulation blocker. So that is another monoclonal antibody. JAK inhibitors, tofacitinib, that is a newer drug, 5 milligram twice daily. Baricitinib, 2 milligram once daily. Like that, so many newer drugs also coming. So we can select any of the drugs that what we discussed here, depending on the availability of drugs in your area, and continue methotrexate even after giving these higher drugs. Before giving any types of immunosuppressants, we have to rule out tuberculosis. That is very important. So at least take an X-ray, chest X-ray, and rule out tuberculosis. see that patient is not having any major disorder like TB or any other problem before starting the treatment. PCP prophylaxis is important in many patients who is having rheumatoid arthritis and chronically on steroid therapy. Next important thing is physiotherapy. Any patient who requires chronic therapy for rheumatoid arthritis, they also require physiotherapy. Once the pain is relieved, we have to start physiotherapy. Without physiotherapy, patients' problem like joint inflammation, contractures will not be relieved. So physiotherapy has got a major role in rheumatoid arthritis. Not only in rheumatoid arthritis, almost all types of joint inflammatory disease. Once the inflammation is settled, we have to start physiotherapy. During acute inflammatory phase, complete bed rest is required, but after that we have to advise the patient for physiotherapy. Proper physiotherapy has to be given to rheumatoid arthritis patients. So we have discussed about one of the important conditions in rheumatology, that is rheumatoid arthritis. Patients with rheumatoid arthritis can come with various problems to emergency room. In that, most important problems are, one is this NSAID induced GI ulcer and GI bleed. Next one is higher dose paracetamol induced liver injury. Third one is steroid induced problem. These patients can have immunosuppression and chronic diabetes. All these things are due to steroids, so they can come with that problem. Then another important problem is all these patients are prone for avascular necrosis of larger bones. So it can be due to rheumatoid arthritis or due to steroid itself. So avascular necrosis is very important. Next important problem is they can come with PCP pneumonia. Any patients who are on chronically on steroids or steroid sparing DMARDs, their immunity will be very low, so they are prone for opportunistic infection like HIV disease. So they should be given PCP prophylaxis. You can give Bactrim DS once daily along with all other treatment. Newer drugs are available in treatment of rheumatoid arthritis, that is biological DMARDs. Before starting biological DMARDs, if you don't take chest X-ray and rule out tuberculosis, afterwards patient can come with tuberculosis and its complications. Other complications like a patient can have ILD related problem, patient can have lung infection, patient can have subluxation of cervical spine. All these things also rarely come to ER. Another important thing is neutropenia. You have already seen Felty syndrome. Many patients can have neutropenia, and associated sepsis also can present to ER. Thank you.